Welcome to Discover Health, a White Mountain perspective. I'm your host, Dr. Tom Barela. Today's program probably may seem a little bit unusual, but we're going to deal with a topic today that almost everyone has to deal with at some time during their lives. Sometimes it's not such a pleasant occurrence, but other times it's okay. And the topic today is hospice. And we're pleased to invite two hospice caretakers to our show today. The first is Ezra Borrego, the hospice chaplain for Accord Hospice. And second, Haley Brosemann, a nurse that takes care of patients for also Accord Hospice. And I'm going to say thank you to both of you coming to our show today. I know it's, for some people, it's a difficult topic. For you, I know that it is kind of a passion of compassion, maybe is one way to look at it. So many people have a difficult time dealing with end-of-life issues, hospice, deaths, and dying. So let's start a little bit by giving our audience a perspective, both from a chaplain standpoint and from a nurse's standpoint. Ezra, can you start and tell how a chaplain approaches the concept of hospice?
First of all, it's a privilege being what we get to do in hospice. You know, you're there in a critical time of a person's life, and also the family that's experiencing seeing a person just break down right in front of their eyes. That's really hard. But being there to give them comfort and understanding what's going to be taking place, and then be able to help them understand that this can be a beautiful thing at the very end, and also a hard thing at the same time. But being there to be able to experience that with the family, because all of us, none of us are going to get out of this alive, and some go sooner than they probably ought to through diseases. But to be there with them at that time with the family and give them comfort, understanding, and to be able to give them peace through prayer, through knowledge that we have through hospice, and to prepare them for things that's going to be coming close in their life. It's what an experience, what a privilege, and an honor to be there for that family.
I'm sure that is emotionally, because you get to learn about people a little bit as they come into your service.
You do, and I got to be there with my mom. My mom passed away 3 years ago, and I wasn't a hospice chaplain at the time, but I got to experience that with my mom, and it was a bittersweet. You know, I'm going to miss my mom, but again, I'm glad she's not hurting anymore, and she was going to be able to be with my dad, and that understanding just brings me a lot of hope and peace, and I can share that with people.
We'll talk a little bit more about how you approach that. But you, Haley, are the one that is responsible for comfort.
Right. And as a nurse, I focus on specific disease processes, whether it be cancer, heart failure, dementia. There are so many different disease processes where we're able to focus on specific symptoms that patients are having that's going to make them comfortable, whether it be pain. Pain is always our main focus. I don't want any patient in pain, and we luckily have doctors that are available 24/7. I can call them up and say, hey, what can you help me with that I can provide these patients so that they're comfortable? I also am able to educate the families immensely on how they can help their family member, because we're not there 24/7, and I want them to feel comfortable in the sense that they're able to provide that care to their family member. So I think that's
wow.
Right.
So your assessment skills have got to be very good.
Right. Head to toe assessments all the time. I take vitals every visit, see where we're at, if we need to stop any medications, increase medications, listen to heart and lungs, head to toe. I want to make sure someone's comfortable.
And that's very important. Somewhere I read that they described hospice as serenity and comfort. I think of you as serenity and you as comfort.
Right.
Well, hospice hasn't been around, at least for a long period of time. So can we start out by giving people just an idea how hospice came about, recognizing what an important role it plays for patients and for families? So
You want to know a little history on hospice?
Yeah, I think that would be understanding for our audience.
So that word is an interesting word. You know, in the medieval times, when a lot of caravans were traveling long distances, they'd have rest spots for people to be under a shelter. And sometimes they'd be just tired from the trip, or they're not feeling well. So it'd be a hospitality location, a rest place. So that's where the word was derived from, was hospitality. So that's where hospice comes from. So and then in England, you know, in Europe, they would there was people there that were starting to find we need something for our people. They need to have specialized places. And a lady by the name of Cecil Saunders in 1948 started this program where they would have a special place for people that were dying, that weren't doing well, that need to have compassion for them and care for them and help them be comfortable. And so she brought some stuff over to university over here in 1963 and did a seminar and kind of introduced that to the United States. And then later on, a lady by the name of Elizabeth Kubler-Ross came over in the early 70s and really introduced hospice to the United States. What a wonderful woman she is. And you can see a lot of things on YouTube about her, Death and Dying book that she wrote back in the early 70s. But she, that's how we got introduced later on to the United States with hospice. And it just started growing from there.
And actually, was it not Kubler-Ross's book, written in the late 1960s, that convinced everyone that it was an important to go through and understand, for people to feel comfortable with what she wrote, which, as you mentioned, is the stages of death and dying. Mm-hmm. The 5 stages of death and dying, a very difficult thing. Mm-hmm. When you do hospice, do you really see people go through all those stages of death and dying, the 5?
From a nurse's perspective, I see they can go from anywhere from 1 to 5, and they're not in any specific order. And they can also go through each stage at multiple times, whether it be anger or denial. And denial is a hard one also, and that's what we come across a lot with hospice, especially when we go to have a conversation with someone about signing on to hospice. Some are in that denial stage at that point in time, and we have to have a conversation with them to help them through that denial stage so we can give them the care that they need.
Are you normally present at the time that a patient is told that they're going into hospice?
Different diseases. We have some patients from the cancer center that yes, we do have some of our staff members present when they are told that it is time, that there's nothing more to do.
Well, let's before we go into a little bit more depth, let's talk. There really are 2 aspects of hospice, the word. One is the death and dying aspect, but the other is palliative care aspect.
Right.
So can we talk about the difference? You're involved more with palliative care, mm-hmm. and from the medical standpoint.
Right.
Okay.
Right.
And can you explain a little bit about what palliative care is?
Palliative care, we have mostly cancer patients that come on with palliative care, in the sense that we want to control their pain before they're even at the stages that they can no longer go through chemo or radiation. So the palliative standpoint is we're available to them, and we have palliative patients. We're available as a nurse or a hospice aide, that we can come and help them with things that they're struggling with at that point in time.
Basically, palliative care is more than just going into the doctor and getting your chemotherapy. Recognizes that when you go home, you need somebody to be there.
Right. Correct.
You need somebody to be there.
Right.
So let's start at the beginning. Give us an idea of how people handle the news that they're going into hospice. You've had a family member that's gone through hospice. I've had 2 parents that have gone through hospice. I remember my mother being told that she was going to go into hospice. And I remember the look on her eyes, on her face, and her first comment was, "You mean I'm dying?" How do you approach that from a comfort standpoint? And you must, as chaplain, must understand that different religions approach death and dying from a much different standpoint. So how do you handle it when you see it? I mean, what are the different reactions that people have?
There are a lot of different reactions. It depends on their experience in life, their religious background, their spiritual background, what's happened to them in their life. So some can come in really in denial and upset. You know, they just like, I can't believe this happened to me. And a lot of times they'll even go into a bargaining state really quick, even along with that denial, anger, and bargaining at the same time. But some people, I've even heard, it is what it is. I've heard that from patients. You know, I accept this. Just it's my journey in life. This is what's happening to me, and I better do the best I can with it. Where some just do not want to deal with it at all. And that's where I come in and help them through that process. That no longer they can do a lot of the physical stuff that they used to do. I let them know that they can still provide information of their life to their family and to me, to share their life with me, because that's powerful. That they can be able to. I let them know they're a book, and part of their chapter is getting ready to really have a tough time, and their book's going to be closed a little bit. I want to know about their book before they leave this existence of this earth. And they get to do that, and it brings them some peace that I can still contribute. And so that helps them through that process of realizing, okay, I can't do what I used to do. This is hard, and this stinks of me having disease. But I can still do something while I'm still here. So I help them through that, and I have prayer with them and talk with the family through all that too. So it's a bittersweet when they start going through that. And some don't do well, and some do okay.
I suspect your role is a little bit of helping them put some finality to the process that they're going through.
Yeah. Yeah.
That you know, despite the fact that their time here with us may be limited, there's still important things for them to do during this time period.
Yep. Yeah, they get to share those things, even though they can't get up and move around and do things that their soul wants to do. Their soul still feels young. Their body's breaking down, and I just help them lead into the things they are able to do still. And a lot of that's to share their wisdom with their family. And if they ever feel a thought come to their mind, I share this with them, that they need to share that with their family, because sometimes it's something that can be really inspiring to their family that will really help them in their life later on to remember what dad or mom or siblings said to them, or grandma and grandpa, that would just carry them for the rest of their life. And they get to share that with them. So that brings a lot of comfort to that patient, to let them know that, man, I'm still of great worth, even though I feel worthless in this bed sometimes and unable to do what I want to do, but I still contribute and give this to my family.
Our audience probably may not recognize this, but you're very emotional right now about the compassion of what you do, and that I'm just impressed watching you talk about that piece of being able to interact with families and understand. Now, as a pediatrician, we don't deal with death and dying very often. But we deal with a lot of chronic illnesses and stuff. And is there palliative care up here on the mountain for children that are going to pass away?
Not for children.
Not for
currently.
Children. Not usually, and the same thing is death and dying. Your services aren't really called on very often for children up here.
It's not at all, I don't think. We have 20-year-olds that we have, but I don't think anything.
Okay.
Yeah.
I know that Phoenix Children's Hospital has used hospice services up here in the past, at least during the time that I was in practice up here. So let's talk a little bit about the comfort piece. You know, a lot of people talk about morphine. Not a lot of people. People talk about morphine as a nice medication for people who are in pain and stuff. And you're forced, I think, into a position where you have to make that assessment often. Are you not?
Often. And not only morphine, because some people don't like morphine or they have allergies. We have the option to use many different pain medications for each specific patient, for whatever pain medication is going to work for their type of pain, to make sure that they're comfortable.
And I think it's important for people to know that your efforts in nursing, because nursing has always been the tender, loving care piece of medicine, is the nurses have always been the most compassionate. But a lot of what you do is under the direction, well, all of what you do is under the direction of a physician.
Correct.
And you have medical directors up here that essentially lead you and essentially give orders that you can apply.
Right. And we meet with a physician every 2 weeks. So we can just go over each patient, say symptoms they're having that we need help controlling, but our physicians are also available 24/7 to our nurses. So we can call them up and say, hey, I've got this going on. This patient needs help right away. What can I do for them? So
I think, I mean, obviously what you do is incredible, because that's the comfort piece that goes along with the psychological piece. But I think it's important for people to know also what happens if a patient gets a cold during hospice, or falls and breaks an arm. I mean, you just don't let those things, well, colds you can't treat, but you wouldn't, what would you do with a broken arm or something?
right, we have patients that falls
sure you
happen
do.
often. So we give the family the option, hey, you want to go to the emergency room and get this treated? And more often than not, they're like, yes, let's fix this. They go to the emergency room, they fix that problem, or they get referrals, they need surgery, they need to be casted. And it's always up to the family and the patient what they want to pursue in solving that problem. And then once they're home and ready, we come right back in, and we're in there visiting to see what else we can help with, and we'll control that pain also.
Yeah, I think it's important for people to recognize that if people are getting palliative care and death and dying, and something happens that's not related to that process, that requires a new investigation and evaluation, that you just don't let the patient suffer.
Right. Infections also. We'll treat infections, whether it be a UTI, a respiratory infection. If we think that they need antibiotics or anything, we will pursue that.
All right. So if a person got a bladder infection, UTI in your terms, that you would try to treat it so they're uncomfortable.
Right.
And I would assume that in many cases that is also an option for families, or is it to treat infections?
Yes. If they don't want to pursue that, they don't have to. It's always left up to the family and the patient, what they want. They're in control.
They are in control. I think that's important. So we're going to talk a little bit later on about some of the rudimentary stuff. But let's talk a little bit about the stages of dying. I mean, you talked a little bit, and Kubler-Ross is something that most people are aware of. Can you talk a little bit? I mean, you talked a little bit about the denial stage, that is the first stage of death and dying, and not everybody goes through that. Mm-hmm. There are a lot of older people that say, "I've spent my time on Earth,
yes,
and it's time to go." Is it related at all to maybe religious beliefs and stuff?
It can be.
It can be.
Depends on how much involved they are into their beliefs and what's happened to them in their life, again. So along with the denial, there's isolation that they go through. They want to separate themselves. They don't want to let their family see them go through this. So they kind of separate themselves from friends sometimes at first. Then eventually later on down the line through their different stages, they want their family to be around. They want their friends to be around. They start realizing as they're laying there, or as they're thinking about all this, what's important in their life. And they have regrets, and they have different things that they go through. You know, as we lay in bed at night, we think about all kinds of stuff. And we contemplate the day, we have a time to contemplate and think. They have a lot of time to really think about their whole life.
And reflect.
And reflect, and regrets, and things they're glad they got to do, travel, whatever. But one of the biggest things that they think about is they want their family to be around. They want to be able to have that relationship with them, to make amends again with people that they haven't been talking to for a while, maybe a sibling or a child. They want to reconnect with that. And I think that's beautiful, because it's if we got to do that every day of our life, to be able to contemplate what a person is going through when they're getting ready to pass, I think we'd really be a little bit more healthy as human beings, because they get to re-examine their life and almost have a life review, laying there in bed, and think about things that are important. But the stages, they're not always there, but some people go through all of them. And the last one is acceptance, just accepting what's happening. And some people go through that right at the beginning. I accept what's going on. Because when we do assessments, we talk about, okay, where are you at? How do you feel about this? Are you pretty mad? Are you upset about this? Some, yeah, I'm pretty mad. I'm pretty upset. Why is this happening? But some say it is what it is. I'm fine with this. And it's just amazing. You can see the difference through the anguish of people as they're experiencing this degression in their body, and how they were in their life and how they are going through this. Because if they have things they're holding on to, they feel they have that agony and they're really moving around a lot and they're not really comfortable with what's going on. But where they let things go and just be okay with it, they're more at peace, and they are able to go through the process a lot more smooth.
Same thing I suspect is true from a nursing standpoint.
I think Ezra is right on point with the sense acceptance. I think acceptance in a patient is important. I notice once a patient has accepted that this is happening, their families even accepted that this is happening, things are a lot more smooth and peaceful, and that's the ultimate goal. I want the families to accept things are going on also, that this family member, whether it be a mother, a father, a brother, an aunt, or an uncle. I have families that have family members sitting on every single chair in the whole living room. And once everyone's accepted that this is happening, it's much more peaceful to sit with this family, and they're ready.
So while you're talking about acceptance and stuff like that, tell me a little bit about how families go through the actual dying process. Because that is, in my experience, is very difficult for families to actually go through the actual end stages of dying, because it really looks like the patient is uncomfortable.
Right. And to elaborate on that, sometimes they look uncomfortable. And that's an education standpoint where the gurgle, the terminal congestion, a family hears that and they're drowning. And we have tools to help with that, atropine, haloperidol, all those medications that we can help with to suppress that gurgle so the family's more comfortable. There's also the Chine-Stokes respirations, which is they're pausing. Yes, the dyspnea, they sound like they can't breathe.
Rapid breathing, yes.
Right. They sound just like they can't catch their breath. And we can use oxygen. We can also use medications like lorazepam, different benzodiazepines that help that patient relax.
Okay, those are things like Valium.
Right.
That helps the patients relax.
Right. So those symptoms are able to be controlled. There are times we can't, and it looks like they're just in agony, and the family's freaking out. They're like, what's happening? What's happening? And you have to, it's a lot of education.
And it's education
okay.
Because the patient really isn't feeling
right.
that
Right.
what they look like.
Right. It's a lot of education. It's okay, this is normal.
And that's why it's so important for you to be there.
Right.
And usually you're there.
Right. As a nurse, when it comes to that time, I have the conversation with the family that I'm putting on this status. It's called imminent status, is what we as nurses call it. So I make that decision when I say the patient usually has about 72 hours left. Sometimes it happens way faster than that. But it's when those symptoms start showing up, the terminal congestion, the Chine-Stokes respirations, changes in their vital signs, that I'm able to sit down and have the conversation with this family, even give them paperwork that they can read over in their free time if this is too overwhelming. Mm-hmm. I don't want to throw all this on you. Right. Here's these symptoms to look out for. You can call me at any time. I'm here to help you. But this is also a tool for you to look at and use, and you can see how you can help your family member also.
Okay, I want to finish with that. We're getting close to our time. It goes quick. You know, I think it's important for families to understand that hospice frequently does not end with the passing of a person. The family still needs support and maybe understanding and explanations, as you're talking about, What's available to the family immediately afterwards?
So I can touch base on that a little bit. As the family, they need the support more than ever at that time, because they're going to go through the grieving process, just like the patient was going through the grieving process as they're declining. The patient's that patient's no longer there, so there's a major void, and so there's going to be a lot of sometimes anger and abandonment, feelings of that loss is just incredible. So for 13 months, we get to be there with the family if they want us to be there. Chaplain, I get to come in and talk to them one-on-one. We have meetings that we have at our office that they can come to in a group, but if they don't want to be in a big group because they're not ready for that, I go do one-on-one with them and help them through that process. Our social worker gets to help with any paperwork with the person that's lost, to change any kind of paperwork with titles, with all that massive stuff, with
Death certificates and stuff.
And it's a pain for them. And then you're grieving and you try to deal with all that paperwork. So we're there to help them through all that also. And we can even go beyond the 13 months. I still see people after 2.5, 3 years with people that need that help to continue to go through that process. Part of them is missing when that patient goes, especially if it's a spouse.
Oh,
It's
yes.
tough.
I suspect that that's very difficult to do. So your services are available even afterwards.
Yep, even the nurse can come
Yes, I go check on patients' families and spouses all the time to see how they're doing, see how I can help, see if there's someone else I need to contact, like a chaplain or the social worker that they need help with, that they're too scared to reach out.
You guys are the actual epitome of serenity and comfort. And I just want to finish with a comment. Who pays for your services?
If a patient has Medicare, usually it's Medicare. A lot of people don't know that Medicare pays for hospice services 100%. It's the only thing that they cover 100%. Patients who are younger, that are not quite Medicare age yet, the private insurance is usually able to help.
Wonderful. And we're going to finish, and I thank both of you for being here. What an example of compassion for a very difficult time in people's lives. And those of you that have been watching our show today, I hope you get an idea of what a great resource hospice can be for you, for loved ones at a very difficult time. And I thank you for watching Discover Health Today, and keep healthy, but recognize that we all have a finite time here on earth today. And thank you.